I won't take much time. So without any further ado, let me introduce you with our guests today. Today's program will be chaired by Professor Dr. Mohammad Fariduddin sir. Today's keynote speaker is Dr. Nazmul Kabir Qureshi. In our panel of experts, we have Professor Dr. Hafizur Rahman sir, Professor Dr. Mir Mosharraf Hossain, Associate Professor Dr. Feroz Amin, and Dr. Laik Ahmed Khan sir. And the whole program will be moderated by Associate Professor Dr. Shahzad Salim sir. Now I'm requesting Dr. Shahzad Salim sir to please take over the control of the program. Sir, please.
Thank you, Dr. Siam. Very good afternoon and welcome to the webinar. The introduction has been given to all. Even then, I like to introduce Dr. Nazmul Kabir Qureshi, the one of the brilliant endocrinologist, currently working as director and consultant of NHA in Uttara. Dr. Qureshi also working as the scientific secretary of Bangladesh Endocrine Society. He has several international and nationally published good quality articles. So we expect that there will be a fantastic presentation by Dr. Nazmul Kabir Qureshi on diabetes and COVID-19, what we need to know. We are very glad to have the eminent endocrinologist as the panel of expert members like Dr. Feroz Amin, working as associate professor in the Department of Endocrinology, Bardem, Dr. Mir Mosharraf Hossain, professor and head, Department of Endocrinology, Sir Salimullah Medical College and Hospital, Dr. M.D. Hafizur Rahman, the General Secretary of Bangladesh Endocrine Society, Professor M.D. Professor Laik Ahmed Khan, ex-head of Department of Endocrinology, Rangpur Medical College, and the program is very much blessed to have Professor M.D. Fariduddin as the chair. But nonetheless, you, the audience, you are the main beauty of the today's program. I request you to learn and listen to Dr. Nazmul Kabir Qureshi carefully and put your question in the Q&A. The relevant questions will be answered after the presentation of Dr. Nazmul Kabir Qureshi. So, with the permission of the chair, we'd like to start the session of Dr. Nazmul Kabir Qureshi. So can we start?
Thank you. Sir, may I start the presentation? Okay, thank you, sir.
Slide share. Okay, fantastic.
Thank you very much, Dr. Salim Bhai, for your kind introduction. And with the kind permission of the chair, I'd like to start my presentation. So today, the topic of the presentation is diabetes and COVID-19, what we need to know. So currently, we are having a global pandemic caused by RNA virus, SARS-CoV virus. And this is the one of 7th coronavirus known to infect humans. And it is called COVID, disease caused by this virus is called COVID-19 because it is abbreviated as COVID coronavirus disease 2019. And currently we know that it has been jumped into the human through wild animals with some intermediate vectors. And it is causing some mild infection, flu-like infection, as well as it is causing the severe form of the disease like ARDS, septic shock, multi-organ dysfunction syndrome. And elderly people and who are having other chronic comorbid conditions like cardiovascular disease, diabetes, CKD, hypertension, cancer, respiratory tracts, and various types of chronic disease, they are more prone to have increased mortality and morbidity contributed by this disease. Usually, there is some presenting symptom, but we have to acknowledge as well that currently we are having many asymptomatic silent cases. In some data, it is found that even 80% patients were found in a small study that they were COVID positive, but they have no symptom. However, most of the cases, the infection causes symptoms, and most common among them are fever, cough, myalgia, fatigue, shortness of breath, sometimes headache, and also a very recently interesting found that some people may initially have some initial symptoms like loss of smell and taste. Eventually, that may turn into with the other development of other features. Uh, Important thing in this slide, which I want to share, is that it's a very infectious disease. High rate of reproductive number and case fatality rate is globally 3%, with high case fatality rates among those with have chronic disease and comorbid condition. So today, this is the global situation. Around 1 crore 24 lakhs are being affected, with a total of death of 5 lakh 58,000 and recover 72,000. This is the picture of Bangladesh. What you can see in this graph, in the most left side of the graph, this is the death reports. In the blue bar, you can see the recovery report, and the orange bar, you can see the active cases. So we are having a step pattern of recovery of cases, and as well as being new affected case. Today, what if we say the effect prevalence rate is 1.7%, with the fatality rate is 1.7% in Bangladesh. Compared, if we compare it, is we can say that yes, a bit low than the global current fatality rate. So this is the current picture. Now let us move with the other perspective. Uh, we have seen that this disease has affected more with the middle age group people who often have hypertension, diabetes, cardiovascular disease, and other respiratory system disease uh, as a comorbid condition. And it has been found that 14 to 22% of the patient may have hypertension, 6 to 11% have diabetes. It's very important. So this is the one important thing, that the people which are being affected by COVID-19 also having some detrimental condition and some comorbid condition that may impose or being affected by the disease itself. So today our focus is diabetes and
আমি কথা
COVID-19.
বলতেন
আমি কথা বলতাম না, কথা শুনতাম।
So in general, we know that those who have diabetes are at increased risk
দেন
of
আগে দেন
any sort of infection, because the diabetes, for diabetes, they have defect or weakening of the innate immunity system, involving the phagocytosis, neutrophilic chemostaxis, and also cell-mediated immunity is also being affected by the hyperglycemia. So it has been found that compared to the normal people, diabetic people often have increased chance of development of respiratory infection, and which may even go to the septic courses, and this both for the viral and bacterial infection. This is very important for the elderly people who have diabetes. They have more chance of being affected with the viral infection. And that there is an increased risk of fatal outcome from COVID-19 infected person, that is, which is 50% higher in patients with diabetes than those who do not have diabetes. Currently, we do not have any national data, published data, but recently we found a report in our national media that in one hospital, uh, if I'm allowed to mention that Mukta General Hospital, it has been found that those who had fatal outcome and those who had been admitted in the ICU, 50% of those patients, 55% of those patients had diabetes. So this is very alarming situation, and I hope very shortly we will get reports from the other hospital as well, and then we can have a national cumulative data. about this scenario in our country. So why there is association? It has been found that the hyperglycemia prefers this virus for entry and for replication. And also, in the other hand, this infection heightens the state of insulin resistant in diabetes. So hyperglycemia and infection, entry, replication are reciprocally helping each other in a positive way. And particularly interleukin 6 are produced that are produced by COVID-19 infection found with the fatal consequence in this patient, and also found that in diabetic patient there is increased expression of this kind of cytokines. We know that type 2 diabetes is kind of chronic inflammatory process is always there. So in this graph, you can see that if you compare with those with no comorbid condition, there is in 7.3% of fatality among those who had diabetes. And another thing is that this infection can lead to the glucose fluctuation of hyperglycemia as well, because there is a deviation from diet, regular exercise. There will maybe symptom of gastrointestinal disturbance like vomiting, diarrhea, which eventually affects the lifestyle, diet, and physical activity. And there may be also interruption of taking oral drugs as well due to vomiting or other GIT upset, nauseous. There is some stress that works on the patient who are being affected by COVID. We have seen in our patient, what we are seeing in our outdoor and there has been increased concern and fear of death that is eventually leading to the stress that again increasing the hyperglycemia. So these are the thing that from the patient part is contributing to the hyperglycemia and deterioration of the infection status. Also, stress can be induced by the glucocorticoid and itself the disease, the cytokines, increased release of cytokines leads to the insulin resistance and deteriorate the glycemic status. So all the things are like a vicious cycle affecting the patient, leading to the patient to the critical or severe cases. So what are the clinical scenario we have to keep in mind while managing diabetic patient during this COVID-19 pandemic? So I have just told you right now that stress is an important factor. And there is a interruption of the normal diurnal rhythm, interruption of sleep. We are not having enough regular physical activity our patient used to do before this pandemic condition. We are having the interruption of the meal pattern. There is also there is a increase less chance of having a increase have a chance of getting a proper and face-to-face advice from the healthcare professionals. And all these things are causing problems and being affected by this pandemic condition that may eventually again causes the glycemic status interrupted. So what we need to advise to our patient in all cases, this we have to know I understand that this is illness. This is a common illness like other illness. We have to follow the sick days rule, but this is a new infection. There is something new. There should be some other rules like home quarantine system should be implemented here, and we should be enough alert to have enough storage of equipments, drugs that should be stored with the patient. So apart from this, how can we stratify our patient and have them glycemic control? Now I'm going to that part. We know in COVID-19 patients are stratified as a mild case, moderate case, and severe and critical. So what should be their glycemic target. There are stratified recommendation for mild and moderate cases who are not elderly. Strict glycemic target can be achieved, which is for fasting blood glucose 4.4 to 6.1 and for prandial 6.1 to 7.8. But if the patient having a mild moderate disease but they are elderly or they are or put on a glucocorticoid, then medium glycemic target should be set like fasting 6.1 to 7.8 and prandial is 7.8 to 10. But if the patient in this ICU setting due to having severe and critical disease and there is a chance of hypoglycemia or very increased fluctuation of blood glucose, patient are elderly having some other serious cardiovascular or cerebrovascular disease or comorbid condition, then you can go for low glucose target, strict glycemic target like fasting blood glucose 7.8 to 10 and prandial 7.8 to up to 13.4. In all cases, we should be very aware to avoid hypoglycemia. Now, the another question comes: what drug we can use and what we cannot use? In all the settings, we have to keep in mind insulin is the best one. But if the patient is not on insulin and patient is having mild disease and managed at home, and there is a less symptoms like having not having much diarrhea, vomiting, or anorexia, then patient can go on with their current regimen, be it oral or be it insulin. Insulin is a no problem. Mild, moderate, severe, critical, all the phases insulin can be used, but regimen can be different. But oral drug, we should be very careful. We have to be cautious about hypoglycemia. We should check for the adverse effect of drugs because we know some drugs can lead to the hypoglycemia. Increased some drugs can cause itself nausea, diarrhea, abdominal discomfort. Some drugs can lead to the fluid retention, and some drugs can cause volume depletion. So we have to, according to the drugs profile, regular drugs adverse effect we have to keep in mind, and then we have to adjust the adverse effect with the current condition of the patient, and decision should be made accordingly. So for mild cases, moderate cases, the usual regimen can be kept, but in hospital, basal bolus regimen is the best choice. But if the patient in critical situation and admitted in the ICU or then having hyperglycemia due to glucose corticoids, then we can go for the IV insulin regimen. And for critical patients, severe patient, all the oral drugs should be stopped. Some cases, continuous subcutaneous insulin infusion can be given, but it is not very practiced in our country due to financial constraint. So this is the point. And another important thing is that we should be very careful about the monitoring of the blood glucose level. In all the cases, we should advise our patient to monitor the blood glucose level when the patient are being treated at home. Of course, when the patient is admitted in the hospital, we do at our own protocol. So this is the thing I think I have said in my previous slide. Well, for particularly some drugs, I'm just going shortly. Some cautious note, like metformin, we have to be very careful for the patient because some patient may have renal impairment, new onset of renal impairment. In this case, we should be cautious, monitor the EGFR, and also adjust the patient condition like nausea, vomiting, diarrhea. If it permits, so metformin can be used, but if not, then eventually insulin should be started. A dipeptidyl peptidase 4 inhibitor are usually well tolerated and can be continued. And we should be very cautious about the SGLT2 inhibitors because itself the drug causes hypovolemia, and often it is very should be wise to discontinue the drug and supplement with the insulin. Same as the glucagon-like peptide 1 receptors, they have some potential GIT adverse effect. We should be careful about it. So in any case, insulin therapy, if the patient gets, should not be stopped. Regimen may be different. We can switch the switch in between the regimens to suit the patient, to fit the patient, the patient condition, patient monitoring status. We should be very careful about, because it has been recorded that during sick days, even blood glucose should be checked every 2 to 4 hourly, even at home. So we have some recommendation. I think I have gone through. So uh, for home management, for inpatient or intensive care, we should regular monitor the blood glucose. Along with that, we should monitor electrolyte imbalance. So often patients are found with COVID-19 with hypokalemia, and drugs can itself lead to the hypoglycemia, vomiting, diarrhea can lead. So electrolyte imbalance is an important factor. We should be always be cautious whether the patient is developing diabetic ketoacidosis. So we should check the blood ketones if available, if not urine ketone. And ABG should be done frequently according to the patient's status. So another important thing is that we do not want infection in diabetic patients. So what measures can be taken to prevent the COVID-19 in our patients? It is very important that we have seen that hyperglycemia is detrimental for any diabetic patient, particularly during this pandemic, COVID-19, and that influences the entry and replication of the virus. So in all cases, all our patients all through for the next coming months should have very good glycemic control. And we should help the patient in every ways, if possible, to telemedicine or video calls, and if needed, through face-to-face contact, to adjust the medication and give the patient a good so to get the real picture and adjust the dose. And for the patient who have other comorbid condition like heart disease, kidney disease, hypertension, dyslipidemia, that should be also focused, stabilized, and treated as needed. It's very important to have proper nutrition, and to focus on the micronutrient as well, because mineral, vitamin D's and other vitamins helps improve the immunity. And who are not vaccinated yet should get their regular vaccination as per protocol. These are the general protocol. By this time, we all know this, that should be meticulously adopted by the diabetic patient in all the cases. We face the patient, be it on the telemedicine or face-to-face. We should encourage the patient to adopt the routine hygiene procedure, which has been advised by our government and international societies to help minimize the infection spread. So what we endocrinologists can do, we at the start of this presentation, I was hearing from our chairperson that currently we in all the hospital who are serving the COVID patient has been equipped with the endocrinologist. So this is a very good news for us. Patients are getting help directly from the endocrinologist regarding their diabetes management, and we are also trying over online to disseminate informations, and repeatedly we are giving the guidelines to our practitioner doctors so that they can help the patient with the proper guideline, treatment regimen, and the advice as well. So we are lucky enough that are now in all our national hospital and even private hospital who are serving COVID-19 patient are being equipped by the endocrinologist. And again, what patients should do, we should always encourage to have them enough stock of medicine, insulin, and other machines they need, like glucometers, strips, for at least 3 months reserve. And we should encourage them to have regular blood glucose checked at home and monitored. They should take the help of endocrinologists to adjust their medication. They should continue their home-based physical activity all along, because exercise and proper nutrition helps improve the immunity. Perhaps this is the only medicine right now to face this infection. And they should always stay hydrated, and only go outside and avoid crowd, and maintain the minimum uh, distance to avoid get infection. But another important now I want to focus, there is a new things, that new things are being discussed nowadays, that whether this is a airborne disease, whether this virus can stay in the air for longer period what we assumed before. Now we have some new data that there is a very low risk of transmission from surface, and very low risk from outdoor activities, but very high risk from gathering in closed spaces like office, religious spaces, cinema halls, gyms, theater. And because the important thing is that viral load, that is very important to successfully infect a person, how much virus is being affected by the patient. That is very important. So new scenario is coming. We also have to focus the information to the patient. And through this graph, you can see in what situation you have a patient have low risk to get infection. In this year, you can see even in the if in the it we go right now to the buffet restaurant, we go out to the gym and amusement park, movie theater, or attend large music concert or sports stadium, or even religious places with more than 500 people. These are the very high risk situation. This should be informed to the patient, because we are now having unlocked situation in our country. So these things should be kept in mind, that which situation we should avoid. For this, I think Japan has done very good, and now these 3 C's, which has been advised by the Japan authority, are now being popular. We have to avoid these 3 C's. First C is we have to avoid crowded places. We have second C is that avoid close contacts, and third C is the confined and enclosed space. During this unlocked situation, we have to always keep this in our mind. This is very important for us, and this is very important for our patient as well. And when these 3 things get combined, it gives us a red zone. So these are the new things, new information, and new adaptive protocol during this unlock situation. We have to keep practicing to help our patient not to get infected by this COVID-19 disease. So thank you very much. I made my presentation. I'm handing over my mic to the moderator.
Thank you, Dr. Nazmul Kabir Qureshi. Now we are at the end of the scientific session, but we will learn from the expert panel members. Still, we do not have any question from the audience. So I am going to the panel members, Dr. M.D. Firuz Amin, the Associate Professor of Bardem General Hospital, to comment on the presentation. And if you like to make any comment, please make it. Dr. Firuz Amin, sir.
আসসালামু আলাইকুম, আমার কথা শোনা যাচ্ছে?
জি জি।
অসংখ্য ধন্যবাদ জানাচ্ছি যে আমাকে এখানে ইনভাইটেশন দেওয়ার জন্য। রেসপেক্টেড চেয়ারপারসন, ডিয়ার অডিয়েন্স, আমি কি একটু রিকোয়েস্ট করতে পারি যে আমার যে কমেন্ট যেটা, সে কমেন্টটা যদি একটু পরে কি দেওয়া যাবে, যে আমার জন্য সুবিধা হয় একটু পরে।
Okay, no problem, sir. Now I am coming to Professor Dr. M.D. Mir Mosharraf Hussain. He is the head and professor of Department of Endocrinology, Sarsorimula Medical College. Please, sir.
Thanks, Dr. Sajada, respected chairperson, panel of experts, moderator, and most of all, speaker. Qureshi. He actually very nicely explained all the things in a very short period. Actually, we are going through a very critical situation, whole world, and in our country, we are also facing a very big challenge. COVID-19 comes the question of management of diabetes in patient of COVID-19. The importance is much more, because not only the diabetic patients are more affected, as Dr. Qureshi told, and as we all know, the diabetic people are more affected by COVID-19. Not only COVID-19, and Dr. Qureshi, he mentioned that infection and diabetes, they are friends. Actually, they are not very good friends. They are bad friends. The patient having diabetes are at increased risk of having infection, and not only they get infected, but the complications arise, and there is very worse outcome. In latest data of diabetic care in USA, 10.9% patients who are affected from COVID were diabetic. That is similar to general population, but the alarming thing is that 24% of admitted patients of ICU have diabetes, and 32% of patients who received treatment in ICU were diabetic, almost 1/3. So we can imagine the grave situation and what consequence, what the fatal outcome a diabetic patient with COVID-19 may bring. In UK also, 19% of patients with COVID-19 who are admitted in the hospital, 19% are diabetic, uncomplicated diabetes, and additional 6.5% had complicated diabetes. So we can see the whole number. And WHO, what they told, that mortality was 9.2% in diabetic patients, whereas diabetic is 1.4%. So it is a big difference. We can just imagine. So the doctor who is treating a patient, COVID-19 affected patient with diabetes, must know two things. One, the staging of COVID-19, whether the patient is in asymptomatic stage, whether he is in mild stage or moderate to severe stage, or in critically ill patient, because the treatment varies a lot. In mild or asymptomatic patient is well controlled, and patient if he is on oral drug, we can continue. But in severely ill patient and in critically ill patient, insulin is the only choice. Insulin is the only choice, and other things we should remember electrolytes also. And one person who is treating patient must know when to refer a patient into the hospital, when he suggests house treatment, and when he will advise the patient to go to the hospital. That should be very clear. That message should be conveyed to every person who is treating patients with COVID-19 with diabetes. And that is the blood glucose persistently above 15 mmol per liter, patient having ketonuria, rapid breathing, abdominal pain or excessive thrust, reduced consciousness, vomiting or diarrhea that persists for more than 6 hours, unable to take food for more than 6 hours, weight loss for more than 2.5 kg, 2.5 kg or more, or patient having comorbid condition, other serious comorbid condition. These patients should not be treated at home. They should be referred to hospital. So these two basic things, what I wanted to emphasize, that staging, and in which stage we can continue oral drugs, and in which stage we should start insulin. That should be very clear. And another second thing is that with diabetic patient, most of the patients are asymptomatic, or most of the patients are having mild symptoms. So most of the patients can be treated in the home, as Dr. Qureshi told. But when to refer into the hospital, that must be very clear to us. And thank you very much. Thanks, General Pharma, for giving me the opportunity. Thanks, Dr. Qureshi, for very nice presentation, as he always do like this. And I must thank Dr. Sajjad in this meeting, webinar meeting. Thank you very much.
Thank you, Professor Dr. Mir Moshar Hussain sir. Now I am requesting Professor Dr. Muhammad Hafizur Rahman to make his comment. Hafiz sir.
So, thanks, Dr. Shahzada Selim, Honorable Chairperson, Professor Mohammad Fariduddin, Chairman, Department of Endocrinology, Bangabandhu Sheikh Mujib Medical University, learned panel of experts, Professor Laik Ahmed Khan, Professor Mir Musharraf Hossain, and Dr. Muhammad Firoz Amin, and learned speaker, Dr. Nazmul Kabir Qureshi, and the moderator of this program, Dr. Shahzada Selim, and respected physicians. Assalamu alaikum. And thanks to General Pharma for arranging this program and inviting me as a panel of expert. So, so thanks our presenter, Dr. Nazmul Kabir Qureshi. And you know that now we are in COVID-19 pandemic, and this is a lifetime experience of healthcare crisis. Not only healthcare crisis, there is also economic crisis. And day by day, people are affected and dying. And many of our colleagues, our friends, our relatives, they are dying and affected. So it is a very deadly disease. So we mourn the death of our departed soul who died, and also we pray and hope that those who are affected, they will recover soon. So now you know that there is a diabetes pandemic and COVID-19 pandemic. So these are the like the double-edged sword. So according to a CDC report, that those COVID-19 patients who have comorbidities like diabetes, other disease, there is the risk of hospital admission is about 6 times more than general population, and about death rate is about 12 times more than general population. So it is a very grave situation. So we have to control diabetes. But now we are in a pandemic. There is an economic recession. There is a limit of resources. And also patients sometimes cannot contact with physicians. So we have to consider, and also we have to consider the drugs that are, whether these are available in every place in our country. So if we consider things that, yes, there is no doubt that insulin is the most important and the most potent and most rapid acting agent. And yes, there is no doubt we can use it, but there are many other drugs. And there is one sulfonylurea. That is the second most potent agent. That is the second rapid acting agent. So we should not forget regarding this use of sulfonylurea, particularly in mild cases. For those who are at home, we are managing them. So we can, if their diabetes is controlled, they can continue sulfonylurea. But if diabetes is not controlled, yes, in that case, we have to consider the insulin. And regarding also other drugs, like patient is getting metformin, patient is getting sulfonylurea as the SGLT2 inhibitors, DB4 inhibitors. Yes, if there is diabetes is controlled, they are at home. And yes, there is some controversy regarding SGLT2 inhibitors, but still, because there is some recommendations from different physicians. There is an international recommendation that is published in Lancet. Also, they recommended that yes, there is no harm to continue this drug at home, because if there is diabetes is controlled. But if we stop this drug, their blood sugar will be uncontrolled. And in this situation, it is sometimes difficult to control their blood glucose at home setting. So I think we should also consider these things. And at hospital admission is no doubt, insulin is the main anti-diabetic agent. And then another thing is regarding the glycemic control. So we know that the COVID-19 in pandemic, there is new onset diabetes. And also those who have pre-existing diabetes, their diabetes becomes uncontrolled. Then Dr. Nazmul Kabir Qureshi mentioned that the main culprit is interleukin 6. Interleukin 6, there is in cytokine storm, interleukin 6, that is responsible for insulin resistance. So in this situation, we have to consider that whether blood sugar is uncontrolled, patient, there is a chance of diabetes ketoacidosis, chance of hyperosmolar hyperglycemic state, there is chance of high severe insulin resistance. So we have to, after all, we have to manage these things. But because we have to consider the whole country, because I don't know that the endocrinologist or expert diabetologist is available in the whole country, remote areas, in remote upozilla. So in that case, even in developed countries like UK diabetes, and also the American diabetes endorsed some guidelines like Montefiore guideline, like Mount Sinai Hospital guideline. They have considered that whether even patient has mild to moderate decay, but patient is stable, patient is well alert, and also in some cases of HHS, and also in severe hyperglycemia. In that case also, we can use subcutaneous insulin, but not IV insulin, because in that they have these guidelines. They propose that in that case, we can measure blood every 4 hourly, because it is very difficult to monitor blood glucose hourly in a remote area. So yes, if in some cases we have to relax, and in some, if it is possible, IV insulin is better in severe and critical illness. So after all, we have to consider, we have to control diabetes. So thanks everybody. So thanks General Pharma and our participants. Thanks everybody. Assalamu alaikum.
Thank you, Professor Muhammad Habibur Rahman. Now, one question to speaker: if you are learning that the mainstay or ultimate treatment option may be insulin, and we know as well that the patient after diagnosis COVID-19, new diabetes may be diagnosed in some instances. In those cases, what will be the treatment policy, Dr. Nazmul Kabir Qureshi?
Yes, it has been found in many, particularly during hospital settings, that we are having new onset of hyperglycemia or new record of hyperglycemia. In that case, we have to, first of all, we have to check the HbA1c. It will guide. If the HbA1c is more than 6.5, then we can have an assumption that probably this is a pre-existing diabetes not being addressed before or being diagnosed before. And if the HbA1c is less than 6.5%, then probably this is new onset of hyperglycemia due to stress and other use of drugs. In hospital settings, in that cases, the insulin should be the drug of choice. But if it is found during the home management, then we can, then again we have to consider the present clinical condition, whether the patient is having diarrhea, vomiting, feeling very sick, having dehydration. That cases, oral drug may not be the good choice. Again, what Hafizur Rahman said, another potential drug is sulfonylurea, and other drugs he have mentioned like SGLT2. We can carefully consider that, but in all cases, insulin is the drug of choice during this sickness period.
One more concern: after treating the patient in hospital with COVID-19, patient did not have was not on insulin prior to hospitalization. During this hospital stay, patient has been initiated insulin, and patient is now discharged and is at home. And for how long insulin should be continued, and how can we switch to OAD?
Yes, this is a very good question, and we also can mention that we have a very good guide or comments or guideline or practice recommendation given by the Bangladesh Endocrine Society. And the last couple of weeks, we are trying to disseminate the guideline across the country. In that guideline, we have repeatedly emphasized that patients should be monitored at home as well after discharge, and continue the hospital management protocol as advised, and should be carefully monitor the patient 3 to 6 weeks. The next 3 to 6 weeks, patient should have a intense monitoring and should keep communication with the hospital. And after that, after 6 weeks, in some very good cases, 3 weeks, patient can be safely disposed to usual medication. That is a common guideline, but it depends upon the patient condition. Thank you.
Thank you for fantastic answer. Now we are going to Professor Laik Ahmed Khan for his comment. Laik sir.
Thank you very much. Honorable Chairperson, very learned panelist, Professor Hafizur Rahman, Professor Amin Hussain, and Feroz Amin. Professor Hafizur Rahman, Professor Mir Musharraf already mentioned about that of treating diabetic patients. So, very little remain for me. I feel whenever we are talking about diabetes mellitus, we should classify into two groups. One, who are not being affected and who are affected. In case of affected patients, she has very nicely pointed out many things, and treatment, management, everything. Way how it is spreading and new news about spreading, she has mentioned. Quraishi has mentioned another thing, that in one hospital, ICU admission was 55% of diabetic patients. Why so high? So we must think in our background that the patients who ICU badly, they were not well controlled prior to be affected by COVID-19 infection. So those who are not affected, their treatment should be up to date and should be maintained in a way that they have got they are treated in a target level. HbA1c and that of fasting and postprandial blood sugar level should be in the target level, so that HbA1c goes down. You must be knowing HbA1c goes up, higher HbA1c, mortality and morbidity rate is very high, even with the change of just 1% of the HbA1c in COVID situation as well. Though we know that even if this COVID develop complications with the increment of HbA1c, I feel this patient should be treated very, very cautiously. Another thing is that whenever we are treating and when managing any patients, whether it is the patients who are not suffering from COVID or the patients suffering from COVID, it should be individualized. And the individualization should depend on many things, what Quraishi has already said. Who are not suffering from COVID, they should be individualized in regards of age, in regards of their economical status, in regards of the glycemic status, and so on. So they should be individualized and treatment should go hand to hand. I'm very thankful to the moderator, Celine. He has very moderated the things. I am really thankful to the audience who has joined here and listening to us. I am thankful to the executives of General who have given us the opportunity to meet together as well as share our knowledge and to see each other. Because in this COVID situation, it's very difficult to meet face to face and to have a journey. So I'm really thankful to all. Thank you very much. Thanks.
Thank you, Laik sir. Now we are coming back to Dr. Feroz Amin sir for his comment. Feroz Amin sir.
Thank you, Salim. Due to some issue, I just pulled back from my initial comment. So thank you very much. Thank you, Chairperson. Thank you, Professor Laik Ahmed, Hafiz Bhai, also the Mamun Bhai, also the moderator Shahjada Salim, and also Master Dr. Nazmul Quraishi for excellent presentation. So what I want to just emphasize that that in this endemic situation, this COVID-19 is diabetes. At least what we know that most of the patients are the diabetic patients are developing the complication like so pneumonia, secondary infection. They need to go for the ICU admission, and most of the time uncontrolled diabetes mellitus cause the admission of our patient. So what we must emphasize that control of the diabetes is very much important. So if you say that most of the drug, whenever acute condition, the infection, blood sugar rises due to interleukin-6, also the virus itself can invade the pancreas, can rise of the blood sugar level. And sometimes we are giving the steroid in our diabetic patient. So there is another cause of rise of the blood sugar. So in that situation, insulin is the one of the answer, no doubt. And we must start the insulin, and whatever we know that we must focus to keep the blood sugar level, fasting, post-meal, and all the day carb of blood sugar must be within the normal range. Fasting around to 6 to 7 and post-meal around to 8 to 10, and HbA1c should be keeping down. So what is happening? You see that another, we know that hypercoagulability one is the factor. The patient is developing the pulmonary embolism, sudden death. And uncontrolled diabetes mellitus is one of the causes that cause the more development in the hypercoagulability. And some of the drugs then cause the more dehydration, and that cause the more hypercoagulability. And some of the drug can cause the more prone to develop the acetone. So as you know that the metformin must be stopped. There is some comment of the SGLT2. From my point of view, SGLT2 must be stopped, and insulin is the answer, no doubt. And there is some study that we can give the DD4 inhibitor, but there is not. There is a hypothesis that the most of the MRS, the virus, coronavirus that have a prone to invade the DD4 receptor. So if you can inhibit the DD4 inhibitor, that can help our diabetic patient, might be the control of the virus. But these are hypothetical. So what I want to say with all my panel of experts, they always advocate to start the insulin. I also advocate that you must start the insulin. The main thing is the control of the diabetes. If the asymptomatic patient, control of the diabetes, no problem, you can continue the drug. But even the asymptomatic patient, diabetes is not controlled. As we know that any patient can develop the thromboembolism, so better to switch over to the insulin in any regimen, whatever your choice. And excellent presentation by Qureshi and moderation. Also, my salam to our chairperson, Furid sir. Also, like I mentioned, my teacher. And again, thanks to Hafizur Rahman and Maun Bhai, all the panel of experts, all the audience in here. And thank you to Jan Pharma to give the opportunity to talk something. Thank you very much.
Thank you, sir, for a nice comment. Now, I am calling upon Dr. Sadia Islam, Senior Manager, Medical Services of General Pharmaceuticals Limited, for his vote of thanks.
Thank you, sir. Honorable Chairperson, today's keynote speaker, distinguished panel of experts, and learned audience, Assalamu alaikum. First of all, let me introduce myself. I'm Dr. Sadia Islam, working as Senior Manager in Medical Affairs, General Pharmaceuticals Limited. So we all know that COVID-19 is a very new and potentially serious coronavirus, which started in Wuhan, China back in December 2019, and it has become a global pandemic. And worldwide, around 4 million people have been infected with this coronavirus. And, evidence are showing that people with comorbid conditions have a higher chance of developing the severity and death from coronavirus. So in this context, we are very much delighted to organize today's live webinar on diabetes and COVID-19, which is powered by Dialytus and Linaptin. So first of all, I'd like to thank today's keynote speaker, Dr. Nazmul Qureshi, for his really wonderful presentation on the topic. Actually, I think this would be very much beneficial for all of us, including who are working as a COVID fighters in the field. So he very beautifully explained the management and other aspects of coronavirus and COVID and the diabetic patients. So I'd also like to thank today's Honorable Chairperson, Professor Dr. Fariduddin sir, for giving us the opportunity, despite all of your very hectic schedule. We are very much honored and inspired by your presence, sir. And I would also like to thank our panel of experts, Dr. Hafizur Rahman sir, Dr. Mir Mosharraf Hussain sir, Professor Laik Ahmed sir, and Firoz Amin sir, for your valuable presence and your opinion on this topic. And special thanks to today's moderator, Dr. Shahjad Selim sir, for a very beautiful moderation on this program. Last but not the least, I'd like to mention that Besides our existing anti-diabetic portfolio, we're currently launching dialysis, which is Voglio's preparation in the market, which will be available from the next week. And once again, dear doctors, thank you on behalf of General Pharmaceuticals Limited and all the doctors who have joined in Facebook Live here, and my colleagues in General Pharma for their concert and collective efforts for organizing this seminar, this webinar. Thank you very much.
Thank you, Dr. Sadia Islam. Thank you, dear participant, and I express my gratitude to the panel of experts. Now, at the end, I am leaving, giving the floor to the chairperson of today's session, Professor Fariduddin sir, for his kind comment and conclude the session. Farid sir.
Thank you, Sunil. Can you hear me?
Yes, sir.
Bismillah ar-Rahman ar-Rahim. Our respected panel of experts, learned speaker, my dear colleagues. First of all, I'd like to thank the General Pharma, particularly the Shah Mani, for arranging such a informative scientific session, which is very much important, particularly in this time. We have learned that diabetes, all of you know, is a chronic debilitated condition. And our new acute infection, the COVID-19, it is a serious acute condition. So association of diabetes and COVID is a very dangerous association, very serious association. We have learned from our speaker about 30 to 50% of our COVID patient is diabetic. And in our country, what we have learned from our various, the front fighter, Bangladesh is also the diabetic, the COVID patient, diabetic is very common. All of you know the diabetes is very common in our country, around 1 in 10. But unfortunately, the bad factors for a diabetic patient, for the bad outcome, almost all are present in our population. Our BMI is low, our blood sugar is very high, average A1C is more than 8, and chronically very high. Associated comorbid condition in our population is very high. On the other hand, the logistics support, the control and the control equipment, which is very low, but due to the low socioeconomic condition and lack of education. Being a poor country, we feel proud that our rural people can get the service by our diabetic association. They've expanded network, but unfortunately, the education is very poor. That's why, in spite of good logistics support and the network, our control is very poor. Almost 80% is uncontrolled in spite of all these things. So all the bad elements, all the bad factors in a diabetic patient which leads to very high death in COVID are present in our population. This COVID, still we have no vaccination, we have no curative medicine. So, learned audience, our main thing is prevention of COVID in a diabetic patient. And we can prevent what our learned speaker says by avoiding the 3C. Avoiding the 3C. Our overcrowded people, if you go to the street, if you go to the market, if you go to the hospital, everywhere, we are overcrowded. To go to the, even in lift, everywhere we are overcrowded. So chance of the aerial spray, chance of airborne infection in our part is very dangerous, particularly if it is so, it will be very dangerous for us. And in spite of even the Prime Minister always educating the people for the face mask, but you go to the market, many we have no face mask. That is very dangerous for us. So prevention of COVID in a diabetic patient is the mainstay or main themes by following the personalizing, avoiding 3C, and with telephonic consultation with the doctors, good glycemic control. Our doctors are very much glad to help our patient. They're very glad to take the telephone to help our patient. So our patient should receive this opportunity to control diabetes from home by telephonic message. Learned audience, as you are the front fighter. And diabetes is very common. So when you are serving our people, when a patient comes to you with fever and suspected COVID, diabetes should be excluded. In our BSMMU, we have already given the few tests for initial investigation, and random blood sugar and hemoglobin A1C is one of them. Exclude diabetes. Because our learned audience and have known, our learned speaker have said in COVID there may be many new onset diabetes, many new onset diabetes of various stages, even mild, moderate, even severe with complications. The patient do not know previously. So every patient who are coming to serve in our hospital, diabetes should be excluded, because COVID with diabetes and COVID without diabetes is a gulf of difference. So we must identify the patient, treat the patient according to patient clinical condition and characteristic of the patient according to our resource. We must treat the patient. Our main objective, good glycemic control without or at least less hypoglycemia. Our regime should be like this, a good glycemic control and less hypoglycemia. And this is an acute and emerging life-saving situation. For good glycemic control is very important. And another one who are working in this field, the patient comes with blood sugar. If more than 15 or 20, ketone body should be excluded. Ketone body should be excluded. Even in low blood sugar, if the symptom is suggestive of ketoacidosis, we must exclude the ketoacidosis. Because many of our patients who are taking the SGLT2 inhibitor in this situation, they may affected by ketoacidosis even in low blood sugar. Another important one is the COVID patient having a low potassium. Their hypokalemic hypertension is present in a COVID patient. So electrolyte is very important. Correct electrolyte, correct blood sugar, correct blood pressure, and the situation what you face, then we can hope for the better outcome. We can hope for better outcome. With these few words, I'd like to thank again the speaker, our expert panel, our audience, and the General Pharma for arranging such important seminar. Learned audience, you are the front fighter. If we help, God will help, because He is waiting to help us, bless us. And this is a national emergency nowadays. And many of our fighters, they are positive, COVID positive. We pray to Allah for their early recovery. Many of our near and dear, they left us. And we pray to Allah for their health. Thank you very much for your patience hearing. And with these few words, I like to conclude this important scientific session. Thank you very much for your patience hearing.
Yes, sir.
After in conclude,
Yes, sir.
Thank
ভালো
you, sir.
থাকেন, সুস্থ থাকেন এবং আমাদের সেই ডায়াবেটিসের স্লোগানটা নিয়ে যান রোগীর জন্য। ঘরে বসে সবই করুন, সুগার মেপে সুস্থ থাকুন।
Thank you, sir.
Thank you, sir. Thank you, sir.
Okay.
Thank you very much.
Okay. Yes.
Okay. Thanks once again, sir.
Okay. Thank you, everybody.
Yes.
Thank you.
Yes. Assalamu alaikum.
Walaikum assalam. Thanks to everybody.
So we can leave.
Yes, sir.
We can leave now.
Yeah.
I am leaving.
বুড়ার আছে বুড়ি।